Sandra, how are you doing today?
Very well, thank you. How are you?
I'm good, thank you. Thank you so much for joining us. So the first question, just want to jump right in there, is that for our upcoming seminar on the 18th of May, you've chosen to focus on the mechanisms and barriers of radiotherapy-induced in situ immunization. Could you just tell me a little bit about why you've chosen this topic and why you think it's an important subject to be discussing?
Sure, of course. So what we have learned is really that in order to develop and progress, tumors need to evade immune recognition. So tumor progression is as much a sort of failure of the immune system to actually control aberrant cellular growth and maintain tissue homeostasis. And so particularly if we want to have durable responses in cancer patients, we really need to address the immune system, to kind of treat the immune system. And so immunotherapy that targets checkpoint inhibitors, these are receptors on T cells that inhibit T cells activity, and has shown, really the ability, has really demonstrated how important is immune control for the tumor, for actually being able to achieve durable responses and controlling tumors, and leading in some cases to very much regulation and kind of, what one optimistically could sort of interpret as potentially a cure. But the problem is that in many patients, the tumor manages to kind of exclude the immune system and does not establish a crosstalk that is conducive to responses to this type of immunotherapy. So what we found is the radiation is capable of resetting the crosstalk between the tumor and the immune system and making the tumor more visible. In part, it does so by activating some of the canonical pathways that are activated normally during viral infections in tissues. And this really exposes the tumor as something dangerous that needs to be attacked by the T cells. So in combination with checkpoint inhibitors, these can improve responses of patients. But, we know that it is, there has been some successes in clinical trials, but also many failures of this approach, which really tells us that we have to understand better what are the barriers and how to use radiation. So I think that, this is really the important area where we need to make progress.
So you were the first to show that radiotherapy can convert tumors unresponsive to immune checkpoint inhibitors into responsive ones. And that's been a finding that's been since translated into several clinical trials. Could you tell us a little bit about the impact of that work in the wider field and what it means for patient outcomes?
Sure. So I started this line of work actually knowing, I should say, pretty little about radiation, but really from the perspective of an immunologist. At the turn of the millennium, I should say, there were new evidence from Nina Barbage's lab and others that cancer cells that die are a good meal for antigen-presenting cells, particularly for the special subset known as dendritic cells that can take the tumor antigen, present them or cross-present them to T cells and activate the T cell response. So I was kind of excited by this idea that perhaps the cytotoxic therapy that is used against tumor could actually enhance, favor this process and kind of act to foster the activation of anti-tumor T cells. At the time, I was actually doing my residency in pathology and looking at breast cancers that had been resected after chemotherapy. And in some of these tumors that responded well, there was a little bit of residual tumor. There were more lymphocytes than there were before the patient received the chemotherapy. So that seemed to me like a supportive evidence, although pretty minimal. And then I heard the lecture of Jim Allison, who was, describing how blocking CTLA-4 in some mouse tumors is sufficient to actually induce complete tumor rejection, but in other tumors that are a little more, less immunogenic, you need to combine that with vaccination, with modified autologous tumor cells. And so I was kind of inspired to consider whether, this sort of cytotoxic agent could actually work with checkpoint blockade in this more difficult tumor, and set out to test that initially with chemotherapy, which is complicated because it can also affect, given systemically, of course, it could also affect the immune cells. And I was lucky to actually meet at the time a radiation oncologist, Silvia Formenti, with an open mind. And so we started to consider using radiation that can be targeted exclusively to the tumor. And that work led to, a lot of interesting findings. But initially, I should say, there were other groups that were working on this, but it did not, I have to admit, it didn't change much. Not much attention was paid to this concept by, the oncology community until immune checkpoint inhibitors were approved for treatment of patients in US. That occurred in 2011 with the approval of ipilimumab. And shortly afterwards, astute clinicians such as Michael Posto and his mentor, Jed Volchok, noticed that, in some of the patients that were treated with ipilimumab, they saw that radiation could, once they stopped responding, radiation of a lesion restored response also outside of the irradiated lesion. So what is known as a scopal effect. And they connected these sort of responses to actually our finding. So that raised a lot of kind of enthusiasm in this new sort of area of cancer immunotherapy. And shortly after that reported case, actually, we had a similar case of an exceptional responder, lung cancer patient who was refractory to all possible, chemotherapy lines with multiple metastases. He was a patient of Silvia Formenti, and she gave him radiation to one metastasis in the liver, and ipilimumab that in lung cancer had not shown really any activity, and the patient responded and is still alive and well to this day. So these are very, encouraging finding. A lot of people did start analyzing retrospectively whether there was a connection between patients that received radiation and were being treated with immune checkpoint therapy. And there were many, analyses suggesting that there is a benefit of radiation in this context. Additional clinical trials started, and a lot of work, a lot of science being done because of, this growing interest in the field. And I must say that, among the clinical trials, there's been some positive ones, but also some negative results. And I think this really is telling us that we, need to understand more. There are very important questions. Radiation is not one thing. It can be used in many different ways. And so there are these outstanding questions that really need to be addressed in terms of how to use radiation, when to use it, where to use it, and how to identify the right combination for a given patient. As an example, I think, a recent paper by Weiping Zhu showed that in patients with liver metastasis, the metastatic environment in the liver actually siphon T cells, anti-tumor T cells, reducing responses to immunotherapy. And radiation of the liver reprograms that microenvironment and actually seems to restore, at least in an experimental model, the responses. So, I think it's very exciting, start telling us that we have to just, there is a lot of potential in using radiation the right way, but a lot of work to be done.
That sounds incredible. And I guess that leads me quite nicely onto the next question, which is just, what kind of research developments would you hope to see within the field in the next, say, decade?
Yes, so I think I would like to really see well-designed, experimental studies, and particularly clinical studies with a lot of correlatives that provide really answer to these outstanding questions. And I know there are many, being done out there, not just in very advanced disease, but also in earlier disease, like in the adjuvant setting, when you can learn a lot about how radiation might modify the tumor microenvironment and how it can interact with immunotherapy. I think we have really to think maybe a little bit differently in, forget about thinking that one solution, can really, that there is a best radiation dose that works for everybody. We really need to kind of get to a targeted, personalized approach in really matching the right treatment with the right tumor and the right patient, because both the, let's say, germline immune system is very different. There are many polymorphisms. I think we have learned very recently how, healthy people can respond very differently to a virus because their immune system is different. And the same thing is true against the tumor. There is, not only the tumors are developing with different oncogenic pathway being activated that can modulate how they respond to the therapy, but also how they respond to the immune system. So connecting really a certain, tumor molecular makeup of the tumor with how to use radiation the right way, how to elicit the right responses, and connect that with the right immunotherapy, I think is where the progress is really going to be made. And, it is exciting that immunotherapy is also progressing very quickly. And I think we can make it. We can make a lot of progress in the next decade. But, remembering to ask, technology is very useful. We have to always keep our focus on thinking and rethinking whether we are asking the right questions when we start a study.
That's great. And how do you hope that the research that you're doing currently will help to benefit patient outcomes?
Yes, so I am really a believer that what we want to achieve is durable responses with good quality of life for patients with advanced disease. And for earlier disease, we want to prevent recurrence so that the patients are cured and don't have to worry about, being at risk for all their life of getting the tumor back and having a bad outcome. So I think the immune system is critical for achieving the goal. We cannot do it without and leveraging the power of the immune system against the tumor, but is not, in itself in terms of getting ways that you can really work with the immune system rather than against the immune system. I think some of the toxic treatment but including radiation can cause lymphopenia. It can cause some sort of effects that really negatively impact the ability of the patient then to mount a response to its whole tumor. So again, I really think that radiation is going to be an important tool, part of the solution in getting this done. We are working, I think, on several concepts that address the two key, I think, mechanisms, two key features that make that, are important for the anti-tumor response. One is what antigens the tumor is expressing, because we know that mutations are very important, but there are a number of other mechanisms beyond just the mutation that can be accumulating in the genes. I think there is a lot of emerging evidence and some that we are working on that radiation can very much alter and we hope improve the repertoire of antigens that are expressed by the tumor cells, so making them more visible to the immune system. And the other thing is to generate the right danger signal, so the so-called adjuvant activity of radiation, which leads to production of cytokine, chemokine, and other types of immune activating signal that tell that they recruit for they really recruit innate immune cells that are kind of like the the one that triage the type of damage in the tissue to alert the adaptive immune system. So we need to really get to understand those two sets of parameter antigens and danger signal, how to get the best combination of these two features using radiation, and how to adapt that to specific patients. Of course, there is a lot to be done, and we are trying to tackle some tumor, particularly breast cancer, where this immune checkpoint, where immunotherapy has had, so far kind of limited success. And I think there is a lot of need to improve that. And so we hope that we'll be able to make some progress in that area.
Definitely. Well, I have faith that you will.
Thank you.
And what is it that you're most looking forward to about your upcoming seminar with us?
Sure. So I'm looking forward to really some, fun intellectual exchange with my colleagues. It's always it's what gets you thinking. When you talk to other people, you tell them your story, and they come out with their perspective. I guess the most rewarding thing, though, would be if I can inspire even just one young person to actually, work on this line of research and take it in a whole new direction in the future.
Definitely. Well, thank you so much. That's all for the questions from me today. Thank you so much for joining me and giving up your time to speak to me.
My pleasure. Nice talking to you.
If anybody listening or watching has any questions that they'd like to give to Dr. Sandra Demaria, then please be sure to join us for the seminar on the 18th of May, where there will be a full question and answer section. All information about the seminar will be in the description bar below, and thank you for watching.